Pain is a normal human experience, but living in pain is not. Take a moment and look at the person sitting on your right. Now look at the person sitting on your left. Chances are, at least one of you has persistent pain. At least 1 out of every 3 people in America suffers from persistent pain, also called chronic pain. Low back pain, neck pain, migraines, nerve pain, you name it. Chronic pain costs the United States over $635 billion a year. This is more than cancer, heart disease, and diabetes combined. Starting at age 26, I myself spent the better part of a decade as a reluctant inhabitant of Painland. I hadn't planned to go there, and I tried my best to leave, but nothing worked. After several months of my initial efforts with no improvement, I took the next logical step. I sought care from my doctor. For the next 7 years, I was medicated, manipulated, massaged, MRI'd, CT'd, and injected. None of it helped. I became fixated on my pain, obsessed with it, a slave to it, hating it, fearing it, fighting it. The author Sonia Huber wrote that pain is prehensile. Something about its nature is to twist, like the delicate but tenacious shoots of a vine, so that it can embed and grab on. It ivies itself into the brick of my structure, weakening it. Pain twists me like the ends of a Hall's cough drop wrapper. This is how it was for me. But here's the thing. Like a Chinese finger trap, the more you fight pain, the worse it gets. The more you fear it, the more threatening it becomes. Pain is a fire, and fear is the fuel. People with chronic pain are standing in front of a fire holding 2 buckets full of fuel. What we need to learn, what the healthcare system should be teaching us but doesn't, is how to stop thrashing around and set the buckets down. How have we as a society dealt with chronic pain? For many years, we have thought about pain in the light of the biomedical model, which assumes that tissue pathology and pain are the same issue. Therefore, an increase in pain means increased tissue injury, and increased tissue issues lead to more pain. Therefore, we treat the tissues with manipulation, injections, and surgery, and when that fails, we use pills to dull the pain. Since the mid-1990s, we have unleashed a devastating wave of heroin-like medications on the world. Opioid painkillers like OxyContin and Norco, all of which are based on the morphine molecule. This little molecule contains both heaven and hell within it. It is merciful and life-saving when used for acute pain, like serious injury, surgery, or those dying from cancer. But numerous studies have shown that treating chronic pain with opioids rarely helps improve pain or function, and often causes harm in the form of side effects, addiction, overdose, and death. In fact, opioids often worsen pain in the long run. Sadly, 90 people every day in America are dying from opioid overdose. The root of the problem is that the biomedical model of pain is incorrect, or at least incomplete. And beyond that, very few healthcare providers get any training in pain management. Let me ask you this. If the tissues at the site of the pain are the problem, then why do our treatments for chronic pain so often fail? Why don't the abnormal findings on imaging scans like MRI correlate at all with pain? Why are 1 out of 3 of us still in pain despite all of our fancy scans, surgeries, injections, and medications? And why are 90 Americans dying every day of opioid overdose? In short, if we are so good, why are our patients so bad? It turns out that pain is much more complex than we used to think. Pain is not a stimulus, it is an emotional experience. Here we see the biopsychosocial model of pain, showing some of the many factors other than tissue problems that contribute to persistent pain. These factors are some of the reasons our tissue-based treatments for chronic pain so often fail. We treat the tissues and ignore the rest. But complex problems require complex solutions. The good news is that if you are living in painland like I was, it is possible to chart your own course out of it with dedication, hard work, and coaching. It may not be possible or even desirable to eliminate all pain, but we can certainly decrease suffering. The basic process works because the nervous system is extraordinarily plastic. This means the brain and the nerves change on a minute-to-minute basis. In fact, all the wiring in the brain is replaced about every 3 weeks. The goal with treatment of chronic pain is to rewire the nervous system in a way that reduces pain while helping someone learn other techniques for coping with pain better. First in this process comes education. We have a saying, no pain, no gain. Research shows that the more people know about pain, the less pain they experience. And anyone can learn about pain neuroscience, even kids as young as 5th graders. Over the next few slides, we will go over some neuroscience education as taught to patients with chronic pain. Now, if you have specific medical questions about your own condition, always consult your doctor. This information is meant for general educational purposes only. Pain is an experience created by the brain in the brain. If you don't have a brain, you can't have pain. Nerves can only tell us about danger by increasing their level of electrical excitement. The brain then decides whether to create pain or not. How does this process work? Here we see a representation of the body's nervous system. It contains over 400 individual nerves totaling 45 miles. All of these nerves are connected like highways. All 400 nerves have a little bit of electricity flowing through them all the time. This is normal and shows that you're alive. Nerves are like alarm systems designed to send us danger messages when there's a threat, such as stepping on a rusted nail. When you step on a nail, nociceptive nerve fibers in your foot increase their level of electrical excitement until they reach a certain threshold at which they fire off a danger message to your brain. The brain creates pain to draw your attention to the injured area to take care of the problem. After you take out the nail, bandage your foot, and get a tetanus shot, over the next several days the nerves in your foot should slowly calm down and the pain eases. Did you know the brain actually produces its own pain medicine? The brain has the most powerful drug cabinet in the world. We call this a wet brain. A wet brain is filled with lots of healthy drugs like enkephalins, endorphins, serotonin, and dopamine that flush down to ease incoming danger messages and the pain experience. A good example is stubbing your toe. When you stub your toe, it really hurts, right? How long? Months? Years? Of course not. It hurts for maybe a few seconds or a minute. In this case, the brain produces pain medicine to dampen the danger messages and ultimately your pain experience. Why does your brain do that? It understands that toe stubbing is not a big deal and in essence tells the system, Calm down, you're making a scene. Everyone is watching. Now, this is key. In approximately 1 in 4 people, the alarm does not go back down to its baseline. The alarm, the nervous system, stays extra sensitive closer to the firing threshold. Tissues have very predictable stages of healing. Most tissues in the human body heal within 3 to 6 months. Ongoing pain is more likely due to an extra sensitive nervous system than an ongoing tissue problem. An extra sensitive alarm system can impact someone's life considerably. In the days before pain, there's lots of room for movement and activities without causing pain. Since developing pain, it takes far less activity or movement before pain is experienced. The limited activity and movement is not necessarily due to injury or tissue damage, but to an extra sensitive alarm system closer to that firing threshold for danger. What causes the alarm system to stay extra sensitive? Everything a person goes through during their pain experience keeps the alarm turned on. For example, dealing with pain every day adds stress and can cause issues at home, school, or work. Treatments aren't working, or the pain would be gone. They've been given several different explanations for the pain, which causes confusion. As long as someone remains stressed, confused, afraid, etc., the alarm system is likely to remain extra sensitive. Knowledge really is the first step in the journey out of pain land. Here's a brain scan of a patient with ongoing pain who's been given various explanations for their pain, but treatments aren't really helping. In row 1, on the top, the patient is relaxing in the scanner, and you can see her brain is calm, no red blobs. In row 2, the patient moves her painful back. All of the red blobs show us her brain processing the pain experience. In row 3, the patient has undergone a short educational session, like this one, and then repeats the same back movements. This time there are significantly fewer red blobs, showing us her pain has decreased. By understanding more about pain and how pain works, we actually experience less pain. In addition to education, there are a lot of other tools to help get the nerves calmed down. This is a huge topic, and there are many great resources out there. If you would like to learn more, many of these are discussed on a podcast called Pain Reframed. I'll just give you the broad overview here. First is sleep. We know that getting 8 to 9 hours of good sleep a night is very important for the brain and the nerves to remain calm, and people who don't sleep well tend to have more pain. Meditation and relaxation techniques can help with stress management, but they also directly calm the nerves and they increase body awareness, which decreases nerve sensitivity. Diaphragmatic breathing is a way to influence the nervous system's balance by affecting the vagus nerve. It tends to make you feel very calm, and that's also helpful for sleep. Aerobic exercise is important because it pumps the blood and oxygen around the nerves, which calms them down. It also makes tissues stronger, and strong tissues are less likely to have pain. Physical therapy is a very good adjunct, in particular for people who are not used to exercising, and physical therapy can help them start exercising without reinforcing the pain cycle. You may be thinking, sure, this pain stuff is all fine and good, but you don't understand. I have a bulging disc, or I have arthritis in my back. Let's think about bulging disc. If we scan the same patient with a bulging disc 2 months later, the bulge is usually about 50% smaller, and 9 months later, it's completely gone. If we scan someone in the morning as opposed to the afternoon, we'll see more disc bulging because the discs are 20% larger in the morning from all the fluid they accumulate during the night. It's the same if we scan someone lying down as opposed to standing up. We see more disc bulging lying down because gravity is pulling the discs into that spinal space. And think about this, 40% of people with no back pain have bulging discs on scans. That's almost half of people with no back pain who have bulging discs. How about arthritis? We know that a human being develops a little arthritis in the spine when they're in their early 20s. As we age, arthritis tends to increase. That's the green line. Now look at the blue curve. This curve shows when low back pain is experienced the most. As you can see, you can have significant low back pain and only a little bit of arthritis, or you can have a lot of arthritis but little to no back pain. Arthritis and back pain are two different things. By the way, we see the same lack of correlation between arthritis and pain anywhere else in the body. You may be thinking, okay, you convinced me on the bulging discs and the arthritis, but you don't understand. I was in a car accident. Did you know that demolition derby drivers crash over 50 times per event, and they participate in an average of 30 events in their lifetime? That's about 1,500 car crashes per driver. And the average speed of these collisions is 24 miles per hour. But only 2 to 3% of demolition derby drivers experience long-lasting pain. There's much, much more, but time is limited. Here are some take-home points going forward. Persistent pain for longer than 3 to 6 months is usually due to an oversensitive nervous system rather than ongoing tissue problems. The nervous system and the brain are extraordinarily plastic. Just like things can change for the worse to create persistent pain, so they can change for the better. Form a team. If you have persistent pain, seek out healthcare practitioners that really understand persistent pain. Ask for physical therapy and participate diligently. Try to avoid medical imaging like x-rays and MRIs for chronic pain unless explicitly advised by your doctor. These tests tend to do more harm than good in many cases. As always, ask your doctor if you have specific questions. Avoid narcotic painkillers for chronic pain whenever possible, and learn other ways to manage acute pain or flare-ups of chronic pain. If you're on narcotics for chronic pain, ask your doctor with help getting off of them. It can be a long road, but you may well find your pain gets better when you are off narcotics. It sounds counterintuitive, but it's true. I have experienced that myself. Learn about the psychological and environmental factors affecting chronic pain. In particular, guard your sleep, manage your stress, make sure you eat a good diet and you're exercising regularly. Cultivate your social networks. Loneliness is a huge cause of stress, and stress is a huge cause of pain. As for myself, I still visit Painland most days, but I see myself as more of a tourist than a permanent resident. I view the strange landscape with curiosity and an open mind. The difference is that now I don't fear my time there. I know what to do to minimize my suffering, even when I experience pain. To those of you whose lives have been affected by chronic pain, know that the tools are there and the tribe is forming. Thank you.